Hello, good evening, and welcome to the second session of our patient education programme for 2025, hosted by Hyperacusis International Specialist Clinics and Research Institute for Misophonia, Tinnitus and Hyperacusis. Hyperacusis International is a multidisciplinary organisation which aims to help you with assessment and management of your misophonia, tinnitus or hyperacusis. Each month, we'll be exploring a different topic within sound sensitivity, aiming to give you a broader knowledge and understanding of these conditions. My name is Joanna Barker, and I'm your host for these sessions. I've been an audiologist for the last 12 years, and I'm a specialist in sound sensitivities. They're my passion, and I'm really excited to bring these live sessions to you. Today, we are kindly joined by Tana Carson and Angela Medina, all the way from Florida. Dr. Carson earned her Master's in Occupational Therapy and PhD in Behavioural and Cognitive Neuroscience at the University of Florida, where she now serves as tenure and faculty member in the OT department at Florida International University. Her research is focused on two key issues for autistic children and their families: sensory processing and learning to swim, water safety. Dr. Medina is a Doctor of Philosophy from the University of Louisiana and Master of Arts and Linguistics from Florida International University. She is currently Interim Associate Dean of Academic Affairs and Tenured Associate Professor of Communication Sciences and Disorders at Florida International University. Her research focuses on stuttering in Hispanic, Latino, and Spanish-English bilingual communities, and counselling and wellness in communication science disorders, where she explores the efficiency of mindfulness for stutterers and speech and language therapy students. Tana and Angelina are sharing with us a presentation on More Than Covering Ears, recent advances in assessing and addressing decreased sound tolerance in children with autism. In this talk, they will be discussing with us recent advances in assessing decreased sound tolerance for children with autism, including their work on screening tools for hyperacusis and misophonia and a checklist for treatment planning. They will also share with us a modified cognitive behavioural therapy approach and a clinical case report. There will be the opportunity to ask questions after the presentation, so please feel free to post these through the chat function. Thank you so much for joining us, and I will now hand over to you both.
Thank you so much, Joanna. Okay, so we'll share our screen. And let me know if you can see everything okay.
That's perfect.
Looking good. Okay. So the title of our talk is More Than Covering Ears, Recent Advances in Assessing and Addressing Decreased Sound Tolerance in Children with Autism. There's a little asterisk there to remind me to tell you that we're approaching this as an occupational therapist and a speech therapist who have seen these things in practice. But I also was raised with an autistic cousin I'm very close with. She's a few years older than me. And so this really is kind of this work just kind of stems from observations of her experiences in life, and then later seeing similar experiences among other families and other children with autism. And so really from the clinic, really wanting tools to better evaluate what we saw and what parents and children were telling us they were having difficulties with, and then also coming up with some evidence-based strategies for working with them. And so we're excited to share this with you today. And we know that Dr. Barker has a lot of experience in this area too. So excited to chat with her at the end and hear any questions and have some rich discussions. So we also have some co-authors, Yushi Cube, Catherine Long, Monica Niebles, and Ashley Tuttle. I'm going to pass it to Dr. Medina.
All right. Yeah, so before we jump into the study, we wanted to make a note about our terminology that we use surrounding autism and autistic person. So we understand that there are people who prefer to be called an autistic person, or there are some who prefer person with autism. We recognize the value of both. So you'll see throughout our presentation that we'll be going in between both of those terms. Next. Right, here's our team. So as Dr. Carson mentioned, we are a multidisciplinary team. We have 3 OTs on board. I come from the speech world, and we also have a PhD student in developmental science, and also Dr. Q, who is our school psychology expert. So these are the definitions that we worked from in developing our research. Hyperacusis, we understand as a type of decreased sound tolerance that entails pain or an unpleasant or frightening response to qualities of sound or volume of sound, whereas misophonia has more to do with specific triggers, and you may see more of a more negative emotional response or a behavioral response. And then there's phonophobia, which is also considered a type of decreased sound tolerance, but it's specifically labeled as a type of phobia in the DSM-5. And within that, there are excessive fear reactions to particular sounds. Here are the numbers. So for prevalence of decreased sound tolerance in pediatrics, recent research has shown that within the population, 50 to 70% of children with autism present with DST. And then we try to break this down further. Hyperacusis, you see the numbers 3.2 to 17.1%. Phonophobia is about 9%. But then we're not clear on how misophonia, how prevalent it is within the population. So that's one of the things guiding this work. How is DST identified? So as of yet, we have descriptive tools, clinical observations, interviews, and self-report questionnaires are primarily used for misophonia and phonophobia, and also hyperacusis. However, hyperacusis could also be further described by using loudness discomfort level testing. However, in my experience as an SLP and with Dr. Carson as an OT, you need an audiologist to help out with that. And sometimes that's not within the client's reach to be able to seek those services. There are existing questionnaires. So there are validated adult questionnaires for hyperacusis. There's a hyperacusis impact questionnaire and also the CALFA hyperacusis questionnaire. We have for misophonia, several of them listed here. And please note that this is not an exhaustive list. These are the ones that we've learned about through our work. There's also phonophobia, which again, that's recognized in the DSM-5. And then we look at pediatrics. There's not so much out there. So our team has developed the pediatric hyperacusis questionnaire. So there's a QR code in the bottom right corner. If you'd like to scan that, it's open access. And also the paper with our data are in the QR code to the top. There are also emerging tools for misophonia specifically. So the Sussex Misophonia Scale, it's specifically for adolescents. And then there's the Misophonia Impact Questionnaire. So even though we have these descriptive measures that I've described, you can do LDL for hyperacusis. We have these questionnaires, but it's still not clear what's going on with the children with autism. And this is a problem because we know early intervention is key. And also just middle childhood is such an important time to identify these, especially at the point of puberty when some of these decreased sound tolerances may be coming up. We need a tool to describe what's going on. So the purpose of our study was to develop a parent report questionnaire where we could identify hyperacusis and misophonia in children ages 6 and up. And we used adult questionnaires that are existing already to help us develop that work. So specifically, we leaned on the CALFA hyperacusis questionnaire and the MisoQuest in the development of our tool. This study's been going on for some time, so there are several steps and several different informants that we have working with us. Our first step was to convert the Hyperacusis questionnaire and the MisoQuest from adult self-report items to parent report items. And we're going to show you an example of how that looks in a moment. We then had the PMHQ, that's the tool that we developed. We shared it with experts and parents via a survey so they could provide us with feedback. We took that feedback and then we made modifications to the questionnaire for parents of children with autism specifically. And then we revised that instrument based on that feedback, and then we field tested our new instrument. I'm going to show you some more details about each of these steps. So here's an example of item translation, specifically for the Hyperacusis questionnaire. Since this was for adult self-report, you can see the item here says, do you find the noise unpleasant in certain social situations? Nightclubs, pubs or bars, concerts, firework displays, cocktail receptions. Those obviously are not appropriate for children. So we had to manipulate what was existing already to make it fit for a child. So on our PMHQ, that same item shows up as, does your child find the noise unpleasant in certain social situations, birthday parties, concerts, dances, and firework displays? On our online survey, we had 9 experts and 20 parents. Experts could be audiologists, speech pathologists, anybody who works with children with decreased sound tolerance. And what we asked them to do is look at our PMHQ and identify what decreased sound tolerance does this map onto? Is it hyperacusis? Is it misophonia? Is it both or neither? And then we also asked them to talk about item clarity, so we could make sure that our questions and items were not ambiguous. And then for the parents, instead of asking about classifying the different items, we asked them to rate symptom occurrence. And we had a scale of never to always. And we also asked them to share their thoughts on item clarity. So we took that information from the surveys, analyzed it, and we identified problematic questions. So items that we were not getting agreement from the experts and the parents as separate groups and together as 2 groups. We also identified items that were frequently marked as unclear. And then we took those items and developed a focus group guide in which we interviewed the experts in one group and then the parents in another to get more feedback on those items. Some of the findings from the focus group, we had experts share that we could tighten up our wording to differentiate hyperacusis and misophonia. We also got consensus regarding the importance of context for misophonia, but also the importance of volume and sound quality for hyperacusis. And then for our parents, they gave us more item content suggestions. So they made us more mindful about the semantics of the words that we were using. And they also shared that one of the words that we had taken from the hyperacusis questionnaire, unpleasant, that what was more important than using the word unpleasant was to focus on certain or specific sounds. They gave us suggestions for context. So again, as we had to change out things like clubs, bars, and so on, they gave us some other examples like movie theaters and dances and things that are more pertinent to their children. And then in the previous version, there are different responses. So aside from just covering their ears, they reported that their children used AirPods, they covered their eyes, they did other things. So to open it up more to the types of responses that we might see.
Okay, so what Dr. Medina was just describing was information that we received from parents of children who were diagnosed with hyperacusis or misophonia. So we wanted to take this a step further, and we took what we learned from those parents and from the experts that we interviewed, and we made modifications to the questionnaire. So we kind of revamped questions based on their feedback and created a new questionnaire, our new version of that questionnaire. So we have some hyperacusis items, some misophonia items on this questionnaire with revisions based on all of that rich feedback that she just reviewed. And then we provided this new version of the questionnaire to parents of autistic children. And what we were really looking for here was, is there anything that we missed that may be unique to how children with autism experience decreased sound tolerance? Are there other types of sounds that are considered bothersome? Are there unique responses to bothersome sounds? And we found that yes, there are some things that were missed that should be included. So when we evaluated our responses from parents of autistic children, we divided them into two basic categories: types of bothersome sounds and responses to bothersome sounds. We also, within those categories, identified themes and sub-themes. So the bothersome types of sounds were divided into two large themes based on context and sound qualities. And you can see that those kind of align with maybe misophonia and hyperacusis. So they gave specific examples of people, places, and things, and also within qualities: pitch, loudness, duration, direction, and white noise. And then within the responses to bothersome sounds, we had four themes: avoidance, distress or anger, physical responses to bothersome sounds, and then communicative responses. And so I think this is the communicative responses and physical responses were really a place that we could kind of unpack how this looks maybe different in autism, where communicating distress, discomfort may manifest in a more physical manner. So pacing, tensing arms, muscles, shoulders. Some parents reported even shaking and specific changes in facial expressions that parents could identify. So we wanted to make sure that we took all of this feedback and that we incorporated it into our pediatric misophonia and hyperacusis questionnaire, the PMHQ, so that all of the questions in the PMHQ would apply not only to parents of children with hyperacusis and misophonia specifically, but parents of children with autistic children who had hyperacusis and misophonia. So all of this happened in step 3, and we got such rich data out of this that we created an inventory or a checklist of these sounds and responses for clinicians to use to further characterize what they were seeing and to help with treatment planning. And so there's a citation here at the bottom for that work that is in press. So it should be coming out soon in the Open Journal of Occupational Therapy, which means it will be open access and the checklist will be included. So we hope that people find that useful. Okay, so after we received all of that wonderful information from parents of autistic children, we incorporated that feedback into a final version, a semi-final version of the PMHQ, the PMHQ-3. So this is the third version of the questionnaire that we have created based on parent and expert feedback. So we field tested the PMHQ-3 with 200 parents of children ages 6 to 17. Some of the inclusion criteria were that the parents could read, write, and speak English. We did not require that anyone had a diagnosis of any kind. So this was just a general pediatric sample. And the pediatric hyperacusis and misophonia questionnaire at this time included 18 parent report items with Likert response options for symptom occurrence. So how often does your child exhibit this symptom? And they could provide a rating on a 5-point Likert scale. There were 8 items for the hyperacusis subscale and 10 items for the misophonia subscale. And generally speaking, what we found was good support for 2 constructs, one being hyperacusis and one being misophonia, which is just what we were hoping we would find. So we really intended to create a questionnaire that could help us screen for and identify hyperacusis and misophonia without overlap in those two. So really trying to identify those two discretely, and they can co-occur, but we really wanted to be able to look at if one was occurring more than the other in a single questionnaire. So we did find some support with that with the two constructs. We also analyzed item content and were able to remove any items that were redundant or that had poor factor loading. So the final result, the final version, at this time at least, is the PMHQ-4. This is a 14-item questionnaire intended for ages 6 to, that should say 17. We have a little typo there, so I want to be clear, 6 to 17 years. The hyperacusis subscale now includes 6 items, and the misophonia subscale includes 8 items. So this is a fairly brief questionnaire that you can use as a screening tool. And we hope that this is an interdisciplinary tool that people use not only in occupational therapy and speech therapy and audiology and psychology, but potentially social work and other professions as well, to really help identify and catch these conditions early on. So now we'll switch gears and talk a little bit about some advances, at least in our work, on how we can approach these conditions within autism. So we know that there's no gold standard currently for addressing DST for autistic patients. One of the things that we see most commonly in rehab is overprotection with sound isolators and earmuffs. So you can see in the bottom left corner here from the show Atypical, they did a really nice job of showing what the day-to-day life looks like with decreased sound tolerance for somebody who's autistic. We know that for adults, cognitive behavioral therapy has some great evidence for decreasing the distress associated with tinnitus, hyperacusis, and misophonia. And there have even been some randomized controlled trials. Again, this is not an exhaustive background on all of the work that's out there, but there's been some wonderful work done in adult populations. So several years ago, I began wondering in the clinic, what about kids? Could this work for kids, particularly for kids with autism? And so when I looked at the literature, it looked like there was strong support for cognitive behavioral therapy with and without exposure for OCD and for repetitive behaviors, in addition to what we already knew it was useful for, which was anxiety. So it kind of gave me the confidence to try it. So the first case that I tried cognitive behavioral therapy with in the occupational therapy clinic was an 11-year-old autistic boy. I reached out to some colleagues of mine, Cindy Gale and Lisa Guerrero, who are in psychology, and they had a lot of experience working with autistic children who had OCD, and they were using cognitive behavioral therapy regularly and very, very well with great outcomes. So I asked them to kind of consult me on this case, and the parents were on board, and so we gave it a try, and it worked really nicely. So I wanted to share that with you today. There's also a manuscript on this case that's open access, and it's available in Frontiers in Psychiatry. And so I provided the reference there for you. So this 11-year-old autistic boy was particularly bothered by whistling, as well as loud sounds like fireworks and loud high-pitched sounds and traffic noise. So when I first asked him, which of these sounds bothers you the most, he said, all of them. When I said, which sound would you like to work on first, he said, whistling. And his parents agreed that whistling was the most problematic for him. So I asked him what he does, and I asked the parents what he does when he hears the sound, and he covers his ears, or he'll ask politely for the person to stop whistling, and that often occurred even if the person was a stranger. He would find that sometimes he would need to hide or escape to a quiet place, and he would avoid certain situations like school assemblies, awards ceremonies, sporting events as well, and shows where there might be clapping and whistling. I asked him if he thought it was possible to hear this sound with less distress or comfort, and he said, no, it physically hurts. Hearing especially his siblings, atomic whistle is like having fireworks strapped to my ears. So this is something that was very distressing for him, but he was willing to work on it. So what my colleagues and I put together was a combination of kind of both of our perspectives of what CBT can include. So that included from the occupational therapy lens, some sensory and arousal self-regulation strategies, as well as some exposure or systematic desensitization approaches and behavior management approaches as well. And we approached it in a 3-phase process. The first phase being psychoeducation, some cognitive restructuring, as well as the sensory-based self-regulation strategies. And then once he was ready, we began some gradual exposure to bothersome sounds within whistling. But we always combined this with a play-based approach. So we made this fun, and we made sure that he was a part of the creative process of developing challenges. We also provided home programs and caregiver education every step of the way. So what did his sound hierarchy look like? We created a sound hierarchy specifically for whistling. And so we used the subjective units of distress scale, and he liked this the improved pain scale below. It made him laugh, and most kids his age, I think, find it funny. So number 1 might be an itch, all the way to number 10 being unconscious level of distress, discomfort, pain. He particularly liked number 5 and 6, bees, question mark. Number 6, bees, definitely bees, I'm running away. So what I like about the improved pain scale is that it's very clear that a number 4 is concerning or bothersome, but I can still function. So as an occupational therapist, that's kind of our sweet spot of the just right level of difficulty, that this is something that bothers me, but I can still function. So anything under that was not considered a problem. So then once we talked about the improved pain scale and what each of those numbers represented, we developed this hierarchy to the right, specifically for whistling. So you can see that a number 4, that tolerable level of discomfort or distress, was hearing whistling 1 time on accident. But he can't really ignore it, and sometimes he might ask someone to stop if it was going to continue. And then that goes all the way up to level 10, which is if somebody was to start teasing him by whistling further, he would get really upset and angry. Okay. So before we engaged in any challenges with whistling sounds, we first mastered self-regulation strategies. So identifying what strategies work for him, what strategies were calming and helpful, and identifying when his arousal level was at a range that he needed to implement those strategies. So we spent a significant amount of time working on that and mastering those skills. And then we could develop our exposure challenges. So the first thing I like to say is that there are some standards that we go by. So the first is identifying the highest level of tolerable discomfort, that level 4, that sweet spot of this bothers me, but I can still function. I can still be present. I can still be engaged in the activities. It's also important to create challenges at that just right level of difficulty or lower. The patient must be involved in the process and agree to every activity. Parents must also be empowered with information about what's going on and be a part of the process as well. And for me, including play, I think it's therapeutic in so many ways for kids. It's how they learn, it's how they engage with the world around them. And it was really helpful in these cases. So we gradually increased intensity of whistling throughout the treatment process, starting with watching videos of whistling. So there is an international competition for whistling on YouTube, which I didn't realize. And so we started looking for whistling videos. And he also enjoyed cat videos, funny cat videos. So his goal was to be able to tolerate watching whistling videos. He could control the volume for a certain amount of time. And then as he got really good at that, we expanded the loudness and the duration of those videos. And then it became an activity that he really enjoyed. And by the time he enjoyed it, then we moved on to something else. So another thing that we did was, as we stepped up through his hierarchy, we used Morse code to play games, puzzle games, where he had to use Morse code to whistle the letter that he wanted to guess to solve the puzzle. And by the time we got through that, he really enjoyed that, and it was helpful for him. So after a series of these sessions and challenges, we were able to kind of reflect back at his final assessment and look at the difference between his initial ratings of these stimuli and his final ratings. And you can see that almost all except for one dropped to the tolerable level or below. So this is illustrating the successful use of a modified cognitive behavioral therapy approach with gradual exposure. But as a parent, how do you approach these conversations or find a provider in occupational therapy or speech therapy that has experience and wants to work on these things with your child? So one of the things that we wanted to communicate was that just ask the therapist if they have training and experience with cognitive behavioral therapy. Ask if they have experience with misophonia and hyperacusis. Do they have experience providing sensory strategies and self-regulation strategies for children with difficulty with arousal and self-regulation modulation? And then also advocating for your child. There are lots of resources throughout this presentation. These questionnaires hopefully will help make an impact and can be something that therapists can use. And then of course, Share International, just a little plug there, unnecessary, because if you're following this, you're already aware of them, but there are so many clinicians there that have experience and may know of an occupational therapist or speech therapist that might like to get involved as well. So we'd like to thank the Wertheim Foundation. The Endowed Innovation Award funded all of our questionnaire development research. We also would like to acknowledge Marta Siepsiak, who was really helpful when we reached out and asked her if we could use the MisoQuest. She was really helpful in guiding us through thinking about how to translate some of the items and giving us her expertise and her experience. Cindy Simon, an audiologist in Miami, that was wonderful in helping us think through this process and networking for recruitment. Francisco Ross, who was instrumental in the cases that I've worked with, children with autism. Kelly Ulmer, similarly consulting on these clinical cases. Our wonderful graduate research assistants, Kate Long, Ashley Tuttle, Shelby McKeever, Monica Niebles, and many master's projects students in the occupational therapy program who have chipped away at this data collection and analysis over the years. We really appreciate their contributions. And when we told our families that we would be on YouTube, they got really excited and the kids asked if we would say their names. So here we go. My family, Wyatt, Forrest, Finley, and Fisher made this work possible for sure. And Dr. Medina's family, Ray, Caroline, and Victoria. We appreciate you all. So here are our contact information if you have any questions, and we're also excited to discuss. We also have a couple of reference slides that I'll just linger on for a second in case anybody wants screenshots. And then I'll go back to the contact information. So we're happy to take any questions that you have. Thank you so much for listening in if you've made it this far.
That was amazing. Thank you so much. I love that your end. My children are very different. When I tell them I'm doing my YouTube video, they roll their eyes. I don't think they'd want to be mentioned. But that was amazing, and that is really really interesting. Thank you so much for that. Can I get you, so I think we've got that last screenshot, so that's perfect. Can I get you to close down the presentation
Sure.
for the moment? Thank you. I found that really interesting. We at Hishio International, we obviously provide cognitive behavioural therapy. We are a multidisciplinary approach, so we do have an occupational therapist who works with us as well, which is brilliant. But what I really love, because obviously we do our appointments via video call because we see people all across the world. We don't do, we have, a patient can see the audiologist, they can see a clinical psychologist, they can see the occupational therapist, but we don't have that sort of combined approach where you sort of do that all in one appointment, which I just find absolutely fascinating. And the way that you tackled the exposure is just really great. And it's something that I actually watched a lecture at BAA, the British Academy of Audiology conferences, and Dr. Jane Gregory talked about this reframing thoughts, obviously this principle of cognitive behavioral therapy, but for children in a way that is fun for them, that they can, she talked about associating mouse sounds with different videos that children found really funny. So I think that that sort of side of it is amazing. Have you done any other bits with other children other than the case study? Yeah.
Yeah, so I would say that I finally found a way to explain it to parents as rebranding, right? So right now, and again, this is all through the lens of autism that I've worked. So if there are other perspectives, I respect that too. But in my experience, it seems like these are classified as bad, right? These sounds that are bothersome are classified as bad, and that starts to approximate to other sounds. So an example is a child who, we're in Florida and we have lots of hurricanes, right? And so they experienced a hurricane and it was traumatic for them, of course. And the sound of the wind blowing was almost like whistling, right? Or almost like a shushing sound. When they were younger, they experienced, unfortunately, abuse at the hand of a caregiver in a school system that was shushing children in her classroom that had disabilities and couldn't control their vocal sounds. So she would shush them, and then there were, it was a negative experience. So then any shushing sound became bothersome, right? Blowing up a balloon for a party. This person loves parties, but blowing up a balloon was reminiscent of those other sounds and became also a bad sound. So we just systematically, I don't know if this translates, but the game of whack-a-mole.
Yep.
As these bothersome, similar sounds popped up that were similar to the shushing or the wind sound, right? We would rebrand them as something fun. So it took time to do that through play, but probably similar to counter conditioning, right? Where, okay, this bothersome sound holds no more power as something bothersome if you're having a blast when you're doing this. So popping balloons became a thing because that's something that they thought was funny. So then popping balloons during a thunderstorm outside. And I mean, we went really far with it. We set up balloons outside and shooting them with a BB gun during a thunderstorm. And then it changed it. So now she can tolerate thunderstorms and the wind blowing and someone blowing up balloons and slowly chipping away at it through play. And that rebranding is kind of how the parents and I decided to call it. We're rebranding this thing. This is no longer going to hold power as something that's negative and bothersome. We're going to make it really fun.
Yeah.
So
I love
that
that.
again, that works for that individual. I don't know that would work for everyone, and it's really
But that's the it's
being
the
at the right time.
patient-centered approach, isn't it? It's finding the thing that works for that patient. You know, what is their like level of understanding? What are the things that they find fun? You know, what language works best for them? So, you know, by having that time with the patient, you get to know them. Were the parents doing some of this at home as well?
That's a big part, right? Is figuring out what translates to the home environment and making sure that everyone's on board, because the consistency is important. It's hard to, I'm just going to keep using the terminology rebranding because that's
Yeah.
what the families like. It's hard to rebrand something if it's only happening once in a while, that it's
Yeah.
fun. It has to be fun every time that thing comes up for it to really be effective. I think it's more challenging if it involves the parents. So oftentimes the bothersome sounds are related to the parents. So making that fun and having, it's a lot of work for parents to be fun all the time. We're doing a lot of things as parents and we can't be fun all the time. So I think that's just, again, that client-centered approach of figuring out what works for each individual in the team. When you're working with children, the parents are an important part of the team. So what do they have the bandwidth to do? And what do they have access to? And how does it fit into their lifestyle and their routines and their habits?
Yeah, definitely. Did you work with, or did you have any work with non-verbal autistic children?
Yes. And so that is a very different experience because really you're relying on the parents to understand their child's cues.
Yeah.
And then really using a lot of the nonverbal cues and really respecting them and establishing a hierarchy of what cues indicate what level on that hierarchy you're at, and taking things very, 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 very slowly and having everyone on board and having reasonable expectations of how far we'll be able to go with this, and when things like headphones are important, right? When some of these coping strategies need to kick in and balance things out to be able to get through the day-to-day activities.
Yeah. That was going to be one of my questions actually. In your presentation, you talked about headphone use. Is that advocated through your general practitioners, or sort of is that the starting point for parents? Where do you see that trend sort of coming from?
I see it coming from desperation of
Yeah.
needing a solution. My child needs to be able to go to school and sit in the lunchroom or sit in the classroom and engage in their activities. And when the bothersome sounds are such that they're having to escape or wanting to escape all of the time, right? It's really impairing their ability to participate. So if the headphones are working in that short term, in this case with the whistling, he was wearing headphones often. And by the time we finished, that's one of the anecdotal, it doesn't show in that line graph, but the parents were so thrilled that they couldn't remember in the last 2 weeks him using his headphones.
Wow.
And it was really exciting to see that change, that they're there for him if he needs them, but he was going to fireworks displays and not using headphones.
Wow.
Which is when you would really expect them to be needed, but he was excited about the fact that he didn't feel like he needed them. He had them there, but didn't wear them.
And that's amazing.
Yeah.
I
And
find sort of where we are, it's almost not from the parents, but from our general practitioners. It's a lack of sort of knowledge around sound sensitivities that general practitioners are sort of going, let's try this. And then not knowing where to go next, not knowing whether to refer to occupational therapy, not knowing whether to refer to audiology, or like it's the knowledge essentially surrounding, and they like you said, they definitely have their place. My worry is what is those patients that told, oh, try headphones, and then nothing else happens. And then when they eventually get to you, you're trying to wean them back from that process, which can be really difficult. So it's just interesting to see, from different countries, how that is, how that's processed between, in the different cultures.
Yeah, I mean, it sounds like a similar process here, and I think it's, and we have in the school system too, when a child has difficulty and it's impacting their ability to participate in school, then they get accommodations, and what's on the menu of options of accommodations. Headphones are on there, right? And so it's a reasonable accommodation and it helps with participation, but it's not necessarily helping with this problem long term. And there are other aspects like hypersensitizing. When you take those headphones off, and you're more sensitive to the world around you.
Yeah.
So it's a challenge, but when it works, and when that's the only option you have, you use it.
Yes, definitely. They definitely have their place, don't they? And it's important to ensure the safety of the patient, and to ensure that they can, like you said, can attend school, that they can go to a social function, because all of those things are really important for their development as well. But it's looking at, okay, well, are there times that we can do something different other than wearing the headphones? It's finding that reasonable approach, isn't it? When we look at exposure techniques, I always have a conversation with my patients of, okay, well, what would we consider is a behavioural ritual that you're putting into place, and what would be considered normal behaviour? So like we will talk about my patients who maybe who have misophonia, don't like eating sounds. And when they go, they'll say, oh, when I go on a train, I'll put my headphones in and I'll listen to some music, or I'll listen to a podcast. And I'll say, but well, I would do that. And because I don't, because I'm on a train and I just want to switch off. So it's going, okay, is this a behavioural ritual that we've put into place? Or is this something that we would do actually, even if we weren't trying to avoid this sound? It's sometimes it can be difficult to distinguish between the two.
That's a really good point. Michelle Garcia Winner has the social thinking program, and I've found that really helpful because there are lots of visual supports for thinking through those socially unexpected or expected behaviors, to help kids think through how to come up with strategies that are not socially conspicuous or that are socially appropriate. So I really like combining some of those visuals with the zones of regulation or alert program visuals, to help kids become empowered with deciding what coping strategies to use in what contexts and what settings. We talk about a lot of deep pressure. So if you're squeezing the muscle bellies on your hands, it can feel calming, right? And so when is that appropriate to do? Well, I could be doing it during our Zoom meeting and nobody really realizes that I'm doing anything out of the ordinary. So that's just a small example, but I like what you're saying about that a lot of these strategies can be social norms.
Yeah. And it's distinguishing between that, because sometimes, our patients are so wrapped up in this world of sound sensitivity, it's all consuming for them. It's really difficult for them to lead normative lives because of the sounds that they have to face, and they don't have the strategies or the support necessarily to help them through this. So sometimes being able to actually take a step back and go, well, actually that would be considered normal. And I actually had a patient recently and she wrote that down. She said, I am normal. And I was like, yeah, of course you are. And she had worked herself up to a point where, she felt like this, she was, very, very different from lots of different people. And I said, actually, to me, somebody who spends a lot of their time talking to people who struggle with different sounds, it's very, very normal. And for her to have that realization really meant a lot to her, and meant that she could sort of move into the next step of acceptance and finding a pathway to be able to manage a little bit better with her sound sensitivity. So
Absolutely.
is the questionnaires, they're available, they can be used? Is that right now?
So the Hyperacusis version of the questionnaire is available open access, and Angela put on that slide that has 2 QR
Yeah.
codes. One is the user-friendly version that Zachary Williams helped us to create, which was so kind of him. And the other has the manuscript with all of the data, and then the version that we used for that study. So there's 2 versions there. And then the pediatric misophonia and hyperacusis questionnaire, the combined instrument, is coming soon. It's under review and we're very hopeful. So we'd love to follow up. Maybe it's something we can put in the comments when
Yeah,
it's available.
definitely. That'd be amazing, because obviously you said like there's lots of different services that would be able to use this questionnaire. Is that right?
Yes, that's the idea, is that we wanted something that's widely accessible, that teachers could be using in schools, something to screen for, and then refer to audiology, refer to occupational therapy, refer to psychology, refer to speech therapy, and any other services that can get on board. So that's the idea, is that it's something that's brief enough that it doesn't take too much time for parents to complete, but thorough enough that it really does help to identify, is this hyperacusis, misophonia, or a combination of the 2.
Yeah, that's amazing. And it'd be so helpful. And again, it's what we touched on, that education, like bringing that education out into sort of the wider field, into schools, into doctor practices, so that, you know, those first people that those children are seeing, because they're not seeing us probably for a long time. So, you know, it's bringing that knowledge out. So, and that's really helpful, because hopefully then they can get referrals into the organizations that they need.
Or they are seeing us, in the case of occupational therapy, for other things, right? So it's very common for kids with autism to be referred to occupational therapy, but as occupational therapists, we really needed tools for identifying these conditions specifically, and then some evidence for what types of strategies to use to help them cope and help them address this challenge.
That's amazing. Thank you so much, both of you. I really appreciate you taking your time to join us. It means a lot. I really appreciate it. If anybody is having any problems with the issues that we've raised today in the patient education program, please feel free to get in touch with Hyperacusis International. As Dr. Tana said, that our website provides lots of interesting resources for patients, families, and health professionals. There are videos, there are links to our patient education program, blogs from past patients, case reports. So there's a lot on there that can be helpful for patients and families and healthcare professionals as well. Our main aim for Hyperacusis International is to provide private consultations and clinics, delivering specialist care to children and adults with sound sensitivity anywhere in the world. As we discussed before, we offer a multidisciplinary team, which involves audiologists, psychologists, occupational therapists, and neuroscientists. Evaluated research on this package has shown very good results in helping patients to manage their symptoms and significantly improve their quality of life. Thank you so much for joining us this evening or today, depending on which time zone you're in. Thank you very much. Bye. Excellent. Thank you, ladies. I have just ended the live stream and stopped the recording.